Fred. Good to see you, Fred.
Nice to see you as well. Jazz told us to hit the record, so I hit the record.
Jazz, he is the brain behind this operation. So thanks, Jazz. We appreciate you. Um, we're very lucky. Parisa is doing teaching points today, and Sohail is doing scribing. Thank you both so much. And Zahir is presenting a case. Zahir, do you want to say hi to everyone?
Hi guys, I'm Zahir. I'm going to be presenting the case today. I'm a third-year medical student who worked with Dr. Bajwa this year.
We're sorry about that, Zahir.
I was like, Dr. Bajwa, who is that? I'm like, oh, Jazz.
Reza, not cool.
I'll be a very big fan of Jazz, aka Dr. Bajwa here. Thank you so much. We're really looking forward to the case. If you can put the whiteboard up, we can get started. And who better than the first aliquot that the one and only Prof Rez. Did you hear that double Prof Rez? It's Prof Rez now. All right. Parisa or Sahil, would you mind, Sahil, pulling up the board whenever you get a chance? Thank you, thank you, thank you. All right, Zahir, we're ready for you.
Alrighty, so today I'm going to be presenting about a 76-year-old female presenting with encephalopathy for the past week. So the patient was nonverbal or semi-verbal, secondary to like voice hoarseness that she's developed pretty recently. So some of the history was taken or given to us from the daughter. So she presented with altered mental status with progressive confusion and fatigue for the last week or so. She also reports mild weight loss over the past month. Other than that, denies any abdominal pain, reflux, any shortness of breath or chest pain, no leg swelling or rashes. She did have a recent GI bug that consisted of nausea, vomiting, and diarrhea, but other than that, no other complaints. And that will end the first aliquot.
Thank you, Zahir. It's a great start to a clinical case. And what I'm going to do is leave all the data except for the hoarseness to Sharmin to comment on, because I really find this hoarseness as quite peculiar and something that really shouldn't be ignored. There's some findings like I have a little bit of belly pain, but they're presenting with confusion. Maybe you don't put so much weight on the belly pain. But if someone says I'm seeing double, or they say I'm hoarse, or they sound vocally different, you really got to invest cognitive energy in that one specific finding. And I think the best way to approach hoarseness is like you approach any other problems. What are the most common causes? That's like branch point number one. And if I ask you, what is the most common cause of hoarseness? You've all experienced it. It's probably speaking too much, especially if you're a gifted and talented teacher like Dr. Bajwa. You're going to want to vocalize all of your knowledge. And throughout the day, by the time you get home, your larynx, and that's where hoarseness really develops. It's like at the level of the larynx with the vocal cord. So speaking too much. And singers have this problem as well, where they actually have to give rest to their vocal cords so they don't sound hoarse. Another very common cause is a URI. Like you've all had URIs, and when you have a URI, people can tell you just don't sound yourself. You sound different. Other common causes is if you drink alcohol, you might sound hoarse. If you smoke cigarettes, you might sound hoarse. So if someone was just coming solely with or telling me, hey, Reza, I sound hoarse, I'd be like, okay, what do you do? Do you talk a lot? Did you recently have a URI? Do you drink alcohol? Do you smoke? But, she's not only coming with hoarseness, and there's other data that Sharmin is going to discuss. And that's why we have to go beyond the common causes of hoarseness. And just to give you one or two examples of going beyond the common causes is that if someone has a mass in their larynx, so like if someone comes in with hoarseness, my next question is, are they protecting their airway? Are they able to swallow their saliva? Are they accumulating liquid in the back of their throat that may be suggestive of an upper airway obstruction? The other thing that I would think about in someone in the hospital is hypothyroidism. For some reason, with hypothyroidism, their voice can change, and it can give you this sort of hoarseness quality to it. So I'll probably leave it at that. And maybe I can ask Sharmin, we've never done this, to just summarize the teaching points, like what she took from my teaching points, and then dive into the rest of the data to layer on what the case is about.
Oh my gosh, I love that. So yeah, yeah. To just to summarize, Prof. Rez's excellent points, and I think that also jumped out to me is that like hoarseness in this setting, it is a complaint that is worth investing some time into better understanding it and going beyond it, like whether it is the culprit or its contribution to this to the factor in this presentation. And I think I love the way you were thinking about whether like it could be something as benign as just like talking too much, which definitely in the past 2 days I've done a lot of, and feeling a little hoarse, or whether we're dealing with a common like systemic is like a thyroid disease that can cause as part of its manifestation hoarseness, or are we dealing for something that is more local, that is pressing against the vocal cords and the larynx like a mass that potentially could be an issue with like protecting the airway, and also like be a setup for an aspiration event in this patient. So that was absolutely brilliant. And to tie into the rest of the presentation for this patient, this is like an elderly woman who's like presenting with about 1 week like an acute altered mental status, like encephalopathy basically. So in regards to the other findings of the mild weight loss, the progressive confusion, the fatigue, uh, the question is like, what is noise and what is signal here? And I do think in whenever with altered mental status and acute altered mental status, we loved our mnemonic, right? Metabolic, infectious, structural, toxins, the mimickers, like seizures, and that we want to think about. For me, like knowing the context of this patient is really important, and mostly like thinking about whether this patient has underlying dementia, neurocognitive process that, or neurodegenerative process that could tie in the hoarseness, because then that would like expand or make me think of this patient a little differently. What do I mean like that? If this is someone who is at baseline has dementia or something, then something as like a urinary retention or constipation, like after a GI illness, can make them altered. But if this is someone who was a few days ago was AO times 4, then it tells you about the degree of insult that this person is suffering that would make them so confused and altered. So then also would lead you to think about like the acuity of the workup and urgency of the workup that you need to do. A couple of things that I always like find helpful from family members about like recent falls would be something that is like helpful to know as well. So I always like read my first pass in altered mental status. However, again, thinking about who this patient is, and then trying to tie in like, oh, whether diarrhea, the nausea, the recent GI bug is relevant, is the hoarseness relevant, and start like as Prof. Reza used to like to do, the Venn diagrams through this Venn diagram and see like what the overlap is. So I'll pause there and then pass the mic back to Zohir for more information.
Great. So in terms of her past medical history, it's significant for anxiety as well as sinus inversus. She also does have history of recurrent falls. In terms of her family history, her brother has hypertension. Her sister also has hypertension as well as hyperlipidemia. No family history of cancer or anything like that. Her surgical history is significant for a cholecystectomy as well as a fallopian tube removal in the past. Her home meds consist solely of oxazepam for 10 milligrams for her anxiety. and she does not have any known allergies. In terms of her social history, she is a large smoker. She smokes 2 packs per day for as long as the daughter could remember. As I mentioned, some of this history was given by the daughter. In terms of her alcohol use, she does have history of alcohol abuse and reports about 3 to 4 drinks per day. No other illicit drug use, no recent travel. She worked as a clerk for about 33 years and she's retired now. And that's pretty much it for the second aliquot.
All right, maybe I'll just take a past medical history and then leave the rest for Prof. Res. And in particular, the one that jumps out to me is the recurrent falls. So what I'm asking myself is why a 76-year-old woman having recurrent falls? And is that related to the progressive nature of whatever is going on? When I think about like falls, and I'm sure I learned this from the great Gurpreet Dhaliwal, is like falls. When you think about falls, it's like what it takes for you to walk, and then thinking about what system can go wrong, from your like a neural access to cardiovascular, like your heart and your lungs that you need, osteoarticular, it's the other one to think about. So and in this patient, like I think is worth thinking about all, but in particular, again, thinking about if that voice hoarseness, is that something neurological going on, and are we just seeing like an aspiration pneumonia as a complication of that could potentially cause some level of altered mental status? And I think a bit more history about the recurrent falls would be helpful in what settings, in a setting of like alcohol use disorder. Is that potentially another clue that we need to investigate a little bit more? But so thinking about your neural axis, thinking about your cardiovascular system and osteoarticular, and I think this person with history of recurrent fall coming with altered mental status at least has bought herself a non-con head CT just to make sure we're not dealing with anything structural, which is like one of your no misdiagnoses, like making sure the patient can protect their airways, and also making sure there's not a huge bleed in the head that you have to think about. Prof. Res, what else jumps out to you?
I love that so much, Sharmin. Your approach to like recurrent falls, it's so good that like it's hard to forget. Like if you apply that, like what do we need to walk? Then it's easy to know what might happen that leads to fall. I think that, what I gather from her, the other data is that, going back to what you said, Sharmin, which was like, what is her baseline functional status? And the fact that she lives alone, to me, suggests that she has good baseline functional status and can take care of her ADLs. So this seems to be a significant delta from where she is usually. The smoking for me, it just really makes me worried when someone says smoking, weight loss, hoarse voice, all because the problem is that the weight loss, although it's non-specific in terms of etiology, it is quite specific in terms of when this disease started. And I don't think her disease just started a week ago. I think you can put a timestamp as it starting maybe a month ago. So it seems like we have a subacute disease that may have an acute component. And just like you said, that the recurrent falls makes you want to get a CT of the head, look for a subdural or look for something abnormal. This smoking history with weight loss would make me want to extend that to the neck, because I mean, the exam is going to be super helpful to see if there is inspiratory wheezing that may be suggestive of upper airway obstruction. But I would have such a low threshold to just look at the anatomical area of the larynx. That's really all I have on that. I don't know if you have anything else you want to layer on that, but I think the exam is going to be helpful.
NTD, nothing to add to Prof. Res.
All right, great. So in terms of her vitals, she was afebrile at 37.2 degrees Celsius. She was hypertensive, 162 over 85. She was slightly tachycardic at 111. Her respiratory rate was 20 beats per minute. Her O2 sat was 96%. Her overall BMI is 19.5. In terms of her physical exam, in general, she was cachectic. She had dry mucous membranes, and as I mentioned, she was pretty much nonverbal, but was able to follow commands. Her neuro exam, she was disoriented to time, but oriented to person and place. She did not have any sensory or motor deficits. Her abdominal exam she was soft, non-tender to palpation with normal active bowel sounds. Her respiratory exam, she was cleared auscultation bilaterally with no respiratory distress. Um, her cardio exam, regular rate, regular rhythm, normal pulses, and no lower extremity edema. In terms of her CBC, her white count was 11.1 with 75% neutrophils. Her hemoglobin was 14.1. Hematocrit was 41, and her platelets were 254. And then in terms of her chemistries, so her sodium levels was 133, potassium was 4.9, chloride was 91, bicarb was 31. Her BUN was elevated at 63, with her baseline being around 5 to 15. Her creatinine was also elevated at 4.3, with her baseline being around 0.4. Her glucose levels were 109. Her calcium was 13.4. Her phosphorus was 6.2. Her magnesium was 2.6. Her liver function tests were within the normal range. Her lipase was 125. And urinalysis showed bacteriuria as well as proteinuria. And that will end the third aliquot.
All right. I'll tackle the physical exam and then leave the labs for Sharmin to tackle. And I think, this physical exam is quite telling. And Zahira, you did an incredible job of gathering and presenting the pertinent information. A heart rate of 111 should concern everyone, especially in someone who's older. This is probably the most ominous rhythm in all of medicine. You may say, well, what about VTach and VFib? Well, yeah, those are worse, but sinus tachycardia, which this likely is, though we're not sure, we'll need an EKG to confirm that, is a concerning finding. It's the body giving a red flag that something is happening beneath, and we need to find out what that is. The BMI is low, 19.5, which goes along with her history of weight loss and goes along with Zahir's exam of this patient having cachexia. And so now you might just really in real time, you would probably think about your framework for weight loss, which gets divided into inflammatory and non-inflammatory causes. Generally, I'm not the biggest fan of an ESR and CRP, but I think what we need to do is look at the labs to see if there's any clues to underlying inflammation. And knowing that if one is present, it has a high positive predictive value, but the absence of a leukocytosis or a low albumin, for example, doesn't completely exclude the possibility of inflammation. She's at risk of non-inflammatory causes of weight loss, just given her encephalopathy. And just like Sharmin so greatly shared an approach to recurrent falls, it's so easy to think about how you can have weight loss. And one category is inflammation, but the other is you just grab something and put it into your mouth. So you have to have access to the food. So if someone is experiencing homelessness, has food insecurity, they won't have access, they may lose weight. You have to have the motor coordination to grab the substance, swallow, put it in your mouth, chew, throw it in the back of your pharynx, and then swallow it. So all that has to be intact. Once it enters the stomach, it has to be able to empty from the stomach and be absorbed. So you can have malabsorptive stuff like celiac disease, pancreatic disease that can lead to weight loss. And then the other category is just chronic end organ disease, like liver disease, heart disease, COPD. That too can lead to weight loss. Then there's this category of endocrine stuff like thyrotoxicosis and diabetes that leads to weight loss. We tend to put that in the non-inflammatory, but it's just an increase for thyrotoxic, increase in metabolism. For diabetes, it's an inability to use the calories that you're taking in. And all of a sudden, you wonder whether the real problem is this weight loss. Why is it happening? And then that leads to additional problems like nutritional deficiencies. For example, thiamine that can lead to encephalopathy. So it's really important to recognize that although she's presenting with encephalopathy, the problem started before the encephalopathy. And I think the encephalopathy, honestly, is just a consequence of whatever has been brewing in this patient. And the way you can make that connection from weight loss to encephalopathy an easy way is through nutritional deficiency. And so I think it would be important to send the thiamine level and then empirically treat with thiamine out of concern for Wernicke's, possibly Wernicke's encephalopathy. That whole idea of ocular problems with inability to walk and confabulation, that's not present in the majority. All these triads and pentads are good if they're all present, but their absence does not at all reduce the post-test probability of these diagnoses. So this is a really tough case because I don't really romanticize the physical exam. I think the history is most important, but when someone is altered and you can't obtain an accurate history, it becomes very, very difficult. It becomes so difficult to understand what problem you're trying to solve. So you almost have a lower threshold to pursue a diagnostic test. But I'm going to pass the mic to Sharmin to see if she has anything else she wants to add on the physical exam and then how she may connect those to some of the laboratory abnormalities this patient has.
That was poetry, Prof. Rez. I loved it all, and I totally agree with you that like that could the fact that she's so catectic, it's like this has been going on for a while, and as you beautifully just said, like during the first and second aliquot is that like, oh, there's something going on, and then maybe there is a trigger for an acute on chronic presentation, which kind of seems like where we're at with her. And I really I love giving thiamine. I mean, it's just so great. Just give it. When it helps really well. And like she's at definitely a risk of like nutritional deficiencies in your approach, to weight loss. It was just beautiful. Looking at her labs and thinking of someone who is like so catectic now in coming in, the fact that she's a normal hemoglobin, that's interesting to me. With everything that is going on, someone who's like appears chronically in a normal hemoglobin, medicine is always surprising. So I wonder if there are two things. One, the two things that I would worry about is that one, she's dehydrated and maybe it's just concentrated, or second, are we dealing with a malignancy that polycythemia might be potentially could be like a paraneoplastic or something that would allow for hemoglobin to be normal in someone that I would not expect to have a normal hemoglobin. But that's just me pontificating. But on to the real thing that is the basic metabolic panel. She's coming in with an AKI and hypercalcemia. Hypercalcemia. I'm a calcium girl, and for the past few days on service, I kept having to talk about sodium. So I'm really grateful for the opportunity to nerd out about calcium a bit. And and I think potentially if you ask me like, hey, does this hypercalcemia could explain the fact that she's a little altered? I would say yes. And I think treating that hypercalcemia and see if her mental status improve will be a good diagnostic, using your treatment as a bit of a diagnostic tool. I think in her, like an albumin level would be helpful. And again, like it will goes to her level of malnutrition. I would expect her not to have a normal albumin. However, I'm just making an assumption. And in terms of like the hyperglycemia, and I'm putting that AKI into context of the hypercalcemia and thinking partly the driver of that would be the calcium. However, with an AKI, the one thing you don't want to miss is the post obstruction. So making sure you get your PVR scan to make sure she's not retaining, and then thinking about both the pre-renal and intrarenal etiologies. But the biggest thing you want to think about here is that a calcium level. And whenever I see a hypercalcemia, I think about whether it's PTH mediated or non-PTH mediated. Oftentimes, as a hospitalist, I don't see enough of like PTH mediated process in the hospital. Whenever people come in to me with hypercalcemia, it tends to be non-PTH mediated. And in someone that, Profess beautifully talked us through about the risk of malignancy she has. Uh, and hypercalcemia's mechanism with malignancy is vast, right? It could be PTHRP mediated, and you can see that a lot with like the squamous cell carcinomas, renal cell carcinomas. And then you have your vitamin D mediated processes, and in that within the malignancies, lymphomas can cause that in addition to the granulomatous process. And then kind of the lytic bone lesion with her history of smoking would be like your lungs. She's at risk of breast cancer, and then myelomas being another one to think about. And then there's like your medication side effects, endocrine, again, like that degree of hypercalcemia. For me, raises the concern for a malignant process in her. So what would I do next? I would treat the hypercalcemia in someone who has an AKI. Fluids. However, sometimes you have to give Lasix, but again, and personally, I like calcitonin. I would give it. I think it's easy to give. It will not cause it's just shifting calcium, but it does sometimes buys you a little bit of time. And the same goes for AKI, depending on where you practice. Some people don't want to give bisphosphonates. I've seen a do bisphosphonate even in that because it takes longer to recover, and presumably her AKI is a bit would be fluid responsive. So I would treat the hypercalcemia and then think about the etiology of hypercalcemia. And I think that can help us make diagnostic process about the underlying etiology of it. Professor, anything else to add?
I just love what you did there. You did both diagnostic reasoning and therapeutic reasoning in like 4 minutes. So it's very clear that you are a calcium girl, and that Jazz will never be one.
Oh, too funny. All right, Zahir, back to you.
Alrighty, so to answer some of those questions, her CRP was 19.2, her ESR was 30, her albumin was low at 3.2, and her LDH level was 189. And then in terms of her hypercalcemia workup, so she had a PTH of 13.1, which was low. Her 25 hydroxy vitamin D level was 90. Her ACE level was 25. Her SPEP was normal. Her UPEP was normal, showing no monoclonal bands. Her PTH-RP was 0.7, which is normal. And as you mentioned, we treated the hypercalcemia with fluids for 4 days, as well as calcitonin administration on the last day of fluids. In terms of her imaging, and it's pretty extensive. So her EKG did show sinus tachy. Her chest X-ray was clear lungs. Her CT of her head showed no findings suggestive of infarct, hemorrhage, or mass effect. Her CT chest showed no findings of malignancy, did show multiple nodules measuring up to 6 millimeters. Her CT abdomen pelvis showed no findings suggestive of malignancy. Her renal ultrasound did show mild right kidney atrophy, but no acute renal findings. CT neck showed no necrotic adenopathy or masses. We did do a MRI angiogram of the abdomen, showing severe renal artery stenosis of the right kidney. And then due to her hoarseness, ENT was consulted, and they performed a fiber optic laryngoscopy, which was showed some mild keratotic changes in the vocal cords. And that concludes the fourth aliquot, and the next aliquot will reveal the final diagnosis.
Professor, I talk too much. Please go ahead.
No way. You can't talk too much. Please, Sharmin, tackle whatever you want. Leave me the rest.
All right, maybe I'll just take some like the first set of labs and then pass the mic to you for your thoughts. quite interesting. Again, going through it, PTH being low points us towards like a non-PTH mediated process, as we were worried about. Fascinating. I believe that. I don't know it off the top of my head, but that's elevated 25 hydroxy vitamin. I think if that is in a console, I often like the first lab I get is like one 25 dihydroxy vitamin D. And then if the 25 hydroxy is elevated, it oftentimes points toward like increase in vitamin D. And in the setting of usually if you have a high elevated 125 hydroxy vitamin D, if you have a low 25 hydroxy, then that points toward the granulomatous process. That is interesting because with ACE being elevated and an elevated vitamin D, I think like it's good for us to think about granulomatous processes in her. Yeah, and I think with the granulomatous processes, we like our what infectious processes like TB, like sarcoids, malignancies like lymphoma would be the things that come to my mind. But I do find that pattern interesting, that the fact that the 25 hydroxy is elevated. What do you think, Rez?
Right there with you, Sharmi Z. And I think two things. One is that there's like, in her BMP, I'm just a little shocked at the bicarb of 31. Because usually when people have kidney disease, they end up having some form of an acidosis and eventually need bicarbonate to keep their bicarb up. But I think we have to be really cautious before we say this is a metabolic alkalosis. The reason we have to be so cautious is that she has such a strong smoking history. There's a good chance she has COPD that's yet to be diagnosed. And so she may be a chronic retainer of CO2. And when you retain CO2, you develop an acidosis. And what the kidneys does in response to that is an alkalosis. It's a compensatory alkalosis. I'm making all this point in that a VBG would be really helpful here, because if that VBG if the VBG shows an alkalosis, I think that's going to be a very, very strong clue to the final diagnosis of something like a milk alkali syndrome. And then you wonder why are they even talking about reflux and abdominal pain in aliquot 1? Now, I don't want to read too much into that in terms of problems, so I want to try to be true to the case. But maybe, Zahir, before I even comment on the rest of the data, do you have a VBG to tell us what the patient's pH is?
Do you want me to comment on that, Zahir? Yeah.
Please.
So we had one on admission, and I believe it was like mildly alkalotic, nothing like I can't remember on the specific numbers.
Got it. Thank you so much, Jazz. That's really, really helpful, because again, it's just like when you don't expect something like, and as Sharmin said, in someone with kidney disease, like they lose their ability to 1-alpha hydroxylate vitamin D. And so they tend to be hypocalcemic. So this is really, really bad hypercalcemia given the context of acute on chronic kidney disease. I say chronic kidney disease because she has an atrophic kidney, and that renal artery stenosis is a very good explanation for that kidney being atrophic. So Sharmin, I guess I have two thoughts. One thought is that if they are alkalemic with hypercalcemia, we just have to obtain more history. Were they taking Tums? Were they taking something that led to the hypercalcemia? That's the history. You might ask the family member, etc. But then with regard to the vitamin D, yeah, that's unusually elevated. And it suggests that she is taking vitamin D supplementation, because you wouldn't expect anyone's vitamin D to be 90, yet alone an elderly woman. Like my vitamin D is probably 20 to 25 at best, because we don't get much sun. Though I started golfing, so maybe I'm getting sun now and the vitamin D is getting better. But
you're living in SoCal now, so it should.
But so I would be curious. I guess history taking, like, right? Ask about Tums, ask about vitamin D supplementation, because maybe what she's done is she's taking so much vitamin D that if we get the 125 vitamin D, it will be elevated because she took so much of the 25 vitamin D and she's just converting it. And that's the active form of vitamin D. That's the form, the 125, that actually causes GI absorption of calcium. So I would be curious on history, any Tums, any vitamin D. And then if it were just solely a granulomatous process, I wouldn't expect the 25 vitamin D to be elevated. I would expect more the 125 because that causes the 1 alpha hydroxylation of the 25. And like very briefly, the vitamin D homeostasis, it basically is you ingest vitamin D, you have 25 hydroxylation in the liver, and then 1 alpha hydroxylation in the kidney, and that's the active form, or the sun automatically gives you the 25 vitamin D. It's really complicated. As far as the keratosis, to me, that just suggests that the vocal cord is thickened, and it's probably thickened because of all her smoking. Like I imagine if someone smokes, the same way the mucosa of the mouth gets thickened, I can imagine the vocal cord gets thickened. So I don't know what the final answer is. What I do know is like I would be curious to a PTHRP, and then I would be curious to a history on vitamin D, on Tums intake. And then anytime you have hypercalcemia in an elderly, you have to think about myeloma. And CT scans are pretty good at picking up lytic bone lesions. And you know, her hemoglobin isn't down, like, but it's something else to consider. I don't know, Sharmin, do you feel, Jazz seems to have a raised hand, but I'm curious to feel if you think there's like, I don't know, I don't feel confident that I can like give my money down to an answer here.
Yeah, you're brilliant, Prof. Rez. Of course, you are brilliant. I think like a great point on the bicarb, and yeah, I think definitely like if you think about the acute insult, milk alkali is like a great thought, and like increased intake, and I do think that probably explains some like the trigger of her symptoms and acuity of it. Although like, why is this lady so catectic? And going back to the weight loss that you had, I think whether that's another ideology for it. I do think, like as you mentioned, like while milk alkali is a good example, probably a good thought about uh, the acuity, the acute presentation. I do wonder there must be something else going on with her, and that I don't know what it is. But I think you're that picking up on that alkalosis was just masterful. Jazz, you wanted to chime in? Mm-hmm.
Yeah, I just wanted to clarify a couple of things. So one was the fact that the PTHRP was normal, Reza. I don't know if you missed that. And then second, the general question to both of you. When she came in, she was so hoarse we could barely hear her voice. Mm-hmm. And then throughout the hospitalization, her hoarseness improved. How would you want to comment on that at all?
Well, I can take a crack since I was the one who was talking about the hoarseness. Yeah, like that's a really good point. So if she came in and she was really hoarse,
go ahead,
Charlie.
Like whenever like people are sick, when they have like strokes, they have like recrudescence of stroke, and I wonder if like whatever pathology she has, like when she's acutely ill, things can get worse. I mean, that's like the most basic thing that I can think of. Whether like an acute illness just put more stress on her vocal cord, or her illness that's made it sound worse. But the other thing is like anything like episodic in nature can do it. But I'm just spitballing, Prof. Rez.
I have no idea, Jazz. I can't wait to learn from you because it seems like that's a clue, but I don't know. One thing I do know though is like I think Sharmin, like the point you made is such a good one. Like milk alkali syndrome shouldn't cause cachexia. And I think like when you have hypercalcemia and such significant weight loss, it's almost cancer until proven otherwise. And if we ask like what kind of cancers, we've ruled out like the paraneoplastic syndromes with PTHRP, but then the other main cancers include lytic malignancies like myeloma, breast cancer that may have metastasized. It's just interesting. She had so many cross-sectional imaging and there aren't lesions everywhere, but a CT chest is not good for breast cancer, to give you an example. But I think, like, I don't know, like in the patient like this with hypercalcemia, probably a PET CT is in order to just make sure you aren't missing anything. But I think that weight loss is quite intriguing. I really have nothing else to add. And I'm looking forward to what the answer is and why the hoarseness resolving is a clue to the final diagnosis. That's going to be cool.
Yeah, I think just to keep dancing with your preference, because if it's anything structural, you wouldn't assume it would resolve so quickly, right? So then it involves like the neuro or metabolic etiologies of it. And other than like neuro, I can't think of, and you mentioned the thyroid. I can't think of like anything else that would do it. I don't know. All right, Jazz, we tried.
No, trust me, this discussion was so great because as the attending on the team, this was like a very challenging case. And but one thing before Zahir goes with the last aliquot, the 125 vitamin D was normal. But the as you guys noticed, the 25 vitamin D was elevated. So go ahead, Zahir.
Yeah. So the hypercalcemia was in fact due to excess calcium and vitamin D supplementation. So again, when we asked the patient originally, she did say that she was not taking any Tums. Not sure if that was simply due to her encephalopathy at that point. Her daughter also was not able to provide us that information. However, the daughter said she went back to her mother's home and she did find a bunch of calcium and vitamin D supplements there, which would explain the hypercalcemia. And as we already kind of mentioned, this hypercalcemia was resolving with fluids and the calcitonin throughout the whole hospital course. In terms of her AKI, also was steadily improving throughout her hospital course with the administration of fluids. So likely just acute tubular necrosis secondary to hypercalcemia, as well as GI losses and decreased oral intake from maybe her enteritis that was pretty recent in her history. And then to circle back to the hoarseness, so we mentioned that that also was improving steadily throughout the hospital course. And then this was kind of a big point of discussion for the whole team. So we contacted ENT again regarding the hoarseness, trying to sort of find like an explanation for this. They said it could be multifactorial again. She does smoke, so maybe the smoking cessation was causing some improvement in her hoarseness. Also, the ENT mentioned that hypercalcemia can just lead to generalized neuromuscular weakness as a whole, and this could cause like dysfunction in the laryngeal muscles, which could, of course.
Whoa! Give me some credit here, Zahir. We Googled it first before we confirmed with ENT.
That is true. That is
That
true.
just wants the credit, okay?
No, I was getting to it. So yes, it was all Dr. Bajwa at first, and then for that reason we did contact ENT, and then we kind of from there started looking into this more, and so we did find there was a couple previous articles that discussed patients with hypercalcemia that also experienced hoarseness. So there was one that showed a 65-year-old male with hypercalcemia who had a hoarse voice, and then it was affecting his communication, but then with resolution of the hypercalcemia, the voice hoarseness improved. There was also studies that showed hypercalcemia has been shown to damage the recurrent laryngeal nerve, and the neuromuscular weakness that the ENT had mentioned could be associated because the calcium can block sodium influx through voltage-gated sodium channels, which inhibits depolarization as well as action potential degeneration. There was two more studies, one that showed that parathyroidectomy in patients with secondary hyperthyroidism showed improved vocal cord dysfunction, likely due to a decrease in calcium levels, which improved muscle strength in both the intrinsic and extrinsic laryngeal muscles. And then there was one more study that showed in a Parkinson's patient that improvement of calcium levels improved Parkinson's Parkinson-like symptoms, including hypophonia. and a 7-year-old. So yeah, that's kind of all we got.
Zahir, that was awesome. You did such an amazing job presenting the case. And, you know, I'm going to give you all the credit.
Appreciate that.
Thank you for taking such wonderful care of this patient.
Can I be Reza and interrupt for a second? So so first of all, Zahir, great presentation. You did such a fantastic job. I'm very proud of how you prepared this and presented it from scratch. I didn't have very much mentoring to do. But I just want to clarify some points that you guys brought up, and I think we forgot to mention this. We were initially concerned for malignancy too. The weight loss wasn't like it was mild, as it was mentioned there, and I wouldn't say she was cachectic, just more just kind of like thin appearing. But she looked very bad on day one, just how encephalopathic she was. But what like we sent out like an SPEP, a UPEP, they both came back normal. There was no lytic lesions, pan scans were normal, there was no esophageal lesions. So when she started like with IV fluids, her kidney function really improved, and same with her calcium. So I understand, like as CP solvers, we never want to just anchor on something that is, you know, just a benign cause, but this was just multifactorial. I think we concluded that this was going on for like weeks, like the just the overall decline after this, you know, GI bug. So it wasn't like a sudden snap thing. So, and this how well she improved, and I just chart reviewed her right now. She's doing well, and like no concerns. Her last calcium was completely normal, and her AKI was completely resolved.
Rafraz, any thoughts, any reflections?
Yeah, I just want to thank Zahir and Jazz for putting this case together. Zahir, it's in your genetics to fly to LA at some point because you are Persian, and that's where Paris is going to be coming too. We'll buy you some kebab.
Yeah.
Yeah, we look forward to having you here. And then I just want to I want to say that Sharmin, you're like, I love reasoning with you because it's, yeah, like I mean that point where we thought the patient was very thin and like making that point that, hey, look, milk alkali shouldn't cause that was a highlight for me. And I know Jazz clarified like it wasn't that bad and it was a little bit thin. So it was like really cool to work with you. And I wish I always had that privilege. Like, I'm not even joking. Like tonight I'm on, I wish I could just run a case by you.
I love discussing with you, Prof. Rez. It's just the best. No, right back at you. It's just always such a privilege, and I always like learn so much, and from you and from all of these cases. And Jazz, and Zahir, I loved the hoarseness piece of it, and thank you for pushing us on it. I'm gonna remember this because I'm like, we were circling it, but we weren't quite there, and I really loved that piece of it. And again, like we all have so much to learn to grow. So thank you for being so thoughtful and taking such a wonderful care of this patient.
Thanks so much, Sharmin. I like that. That's what both Zahir and myself and the senior resident, we were just kind of going back and forth. Like, how do we explain this hoarseness that's getting better? And so, it's part of being this community. It promotes you to dig deeper. So, thank you all. This was such a fantastic discussion.
Yeah, thank you guys so much.
Yeah, thanks, Zahir. A pleasure meeting you. All right, Parisa, mic to you. And thank you, Sahil, for scribing.
And thank you so much, Sahil, for bringing this case. It was an amazing discussion. We started with a patient who came in with hoarseness, and we learned about hoarseness framework. We need to think about benign causes, including speaking too much and the person who are singing, because this will cause to larynx irritation. We also need to keep in mind URIs, infections, and we also need to think about drinking alcohol and smoking. Local causes might also present with hoarseness because there are some mass might pressing the vocal cords and proning the patient to airway obstruction. The systemic causes might be like hypothyroidism. We talk about altered mental status, although we have the famous schema, but we also need to keep in mind the tempo of the symptom onset and the baseline functional and physical cognitive status of the patient, because these could guide us through the clinical urgency and the diagnostic process. For example, something like urinary retention and constipation might be present, like altered mental status. We talk about recurrent falls, and we learn that progressive nature of the underlying disease. It is really important to keep in mind what system could be affected in this process. For example, the neuroaxis might be affected, osteoarticular, cardiovascular system, like heart and lung. And for example, aspiration event like pneumonia might be the complication of that specific event. And the complication of this event might be subdural hematoma, and we need to obtain the head CT scan to make sure that nothing is happening in the background. We also learned that tachycardia in the older patient is always concerning, and we need to confirm it with the persons need to be confirmed by obtaining the EKG. We approach the weight loss. We have the inflammatory causes. We need to get ECR and CRP. We also differentiate it into malabsorptive causes, chronic end organ damage like liver and heart, and COPDs might be presented with weight loss. Endocrinopathies like thyrotoxicosis and diabetes mellitus might be presented with weight loss. Many vitamin deficiencies like thiamine might be presented this way, although not all the time. They could have ocular presentation, confabulation, or instability to walk. We also approach cachexia with normal hemoglobin, and we learned that it is a really tricky presentation because the patient might be dehydrated, or they might have some underlying malignancy and they have a polycythemia, because usually we expecting someone with cachexia to be having anemia. We also approach hypercalcemia, which is PTH mediated or non-PTH mediated. We are seeing non-PTH mediated mainly in the hospital setting. The malignant etiologies are mainly lung and renal cell carcinoma, which are secreting the PTHRP. It could be vitamin D related lymphoma, breast cancer, melanoma, and bone metastasis. We learned that how to manage this hypercalcemia. We need to flow therapy our patient, give them calcitonin, Lasix might be needed, and bisphosphonates. We talk about also non-PTH related causes like granulomatosis, TB, sarcoidosis, and other malignancy. In this setting, 125 hydroxyvitamin D is elevated, but 25 vitamin D it's not elevated. We also learned that in patients with COPD, they are usually having chronic CO2 retention, and they should have respiratory alkalosis, and they have compensatory renal response, and they are having increasing bicarbonate production. We also learned that hypercalcemia could cause generalized neuromuscular weakness presenting with hoarseness, and the reason for that is that calcium could block sodium influx through voltage-gated sodium channels, and calcium level might also shown to proning patient to ameliorate Parkinson-like symptom like hypophonia. Thank you, everyone.
Parisa, that was amazing. Thank you so much for capturing all the teaching points and even more. I just love hearing you guys summarize at the end. It's just masterful. Thank you so much, everyone. This made my day. Have a great one. We'll see you tomorrow. Bye.
Hi, guys.
Bye.